Hello, everyone. My name is Jennifer Nosker, and we are pleased that you could all join us for this week's lecture in our Know Neuroanatomy mini-series that brings you lectures from experts in the field covering different neuroanatomy topics each week. So this series was created by early career neuropsychologists to provide free, high-quality didactic opportunities. And we would also like to recognize our Know Neuroanatomy Planning Group for their hard work on Volume 2 of this mini-series. We'd like to thank our sponsors for their financial support for the series. And before we start, we want to make everyone aware of our YouTube channel. Every Know Neuropsychology and Know Neuroanatomy lecture is available for your viewing. Be sure to go check it out, subscribe, and like our lectures. Now, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speaker are their own. Now, questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now, it's my pleasure to introduce Dr. Darlene Floden for today's lecture titled The Cerebellum. Dr. Floden completed her PhD at the University of Toronto, where she studied cognitive neuroscience and clinical neuropsychology with Dr. Donald Stuss, one of the pioneers in frontal lobe function. She completed her clinical fellowship at the Toronto Western Hospital, specializing in deep brain stimulation, epilepsy, and stroke. She developed an interest in the cognitive functions of the cerebellum while working on the acute stroke unit during fellowship, where she saw patients with clear neuropsychological deficits after circumscribed cerebellar infarcts. She's currently a staff neuropsychologist and scientist at the Cleveland Clinic and an assistant professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. She conducts clinical evaluations for the Deep Brain Stimulation Program, the Epilepsy Surgical Program, and the Cerebrovascular Center. She has several NIH-funded research programs, including cognitive outcomes in functional neurosurgery, population health strategies for cognitive screening, and the cognitive electrophysiology of the basal ganglia and cerebellum. Dr. Floden, it's wonderful to have you today.
Thanks for inviting me. I always revel in the opportunity to talk about the cerebellum, which makes me a bit of a dork, but that's all right.
Well, I think you were in good company here.
Yeah, you might as well own that. The idea of an entire neuroanatomy kind of learning online session is just music to my ears. So let me stop talking long enough to figure out how to share my screen.
Absolutely.
All right, can you see that?
Yep, looks great.
Good. Okay. All right. Well, then, hello, everybody. I am Darlene Floden. I'm going to tell you a little bit about the cerebellum. And this is going to be, so first of all, I'm a neuropsychologist. You've already mentioned that. So we're going to talk a little bit about the kind of structural neuroanatomy. And then we're going to spend the second half talking about the functional neuroanatomy, because I think, our neuroanatomical knowledge is really what we want to bring to bear to apply to the clinical assessments of cognition that we do in our patients. So there's a little animation for you just to jazz things up. I like to be not terribly boring when I talk about neuroanatomy because it can put a lot of people to sleep. So I don't know if you remember this guy. He met a rather ignoble end, but nonetheless, we're going to borrow his image for a little bit and do a little bit of a quiz first, okay, about the cerebellum. So talking about neuroanatomy, the cerebellum contains what proportion of the brain's total neurons? Is it 5 to 10%, 20 to 30%, 40 to 50%, or 60 to 80%? Grab a pencil and write down your answer, because we're going to go through and check these in a little bit. All right, so pick your guess. Second question for you. The cerebellum constitutes what percentage of the brain's total weight? Is it 10% of the brain's weight, 25%, 40%, or 60%? Okay, take your guess. And then the last question. If unfolded, when you unfold the cerebellum, how much of the cerebrum, so the cerebral cortex surface, would the cerebellum cover? 10%, 25%, 50%, or 75%? Okay, so make note of your answers. We'll go through, we'll give you the answers as we go, all right? Okay, so today we have a few learning goals to go over. One, we want to understand the anatomy of the cerebellum as the basis for its role in cognition, because this is a relatively new idea, and the anatomy really holds the key to understanding how it could be participating. Two, we're going to review theoretical accounts of what its functional role actually is, very briefly. And now we're then going to discuss 3 neuropsych profiles. I'm going to talk about 3 patients that really give, depending on where their damage is, what kind of deficits we see from a cognitive perspective. And then last, we're going to talk about how we take this into account in terms of designing clinical assessments, because I think most people on this call are probably studying neuropsychology. And so this is really the end game of understanding all the rest of this information. All right, so first of all, we're going to start with cerebellar structure. We're going to go through the gross anatomy, a little bit about internal circuitry and connectivity. And if you're the kind of person that's really excited about organization, you're going to love the cerebellum. So to start with, here's the structure we're looking at. This is the cerebellum and brainstem and midbrain that have been dissected from the rest of the brain. So on the left here, you see the posterior, the back view from the cerebellum. You see the hemispheres on either side, and then the vermis is that little worm-shaped guy down the middle here. This is on the right side is the ventral or the anterior view. So this is looking kind of through somebody's throat, basically. And you see the midbrain here, the medulla, the brainstem, and then here on either side emerges the hemispheres of the cerebellum. But now you can see the flocculus, kind of this little lumpy guy that's emerging at the top, and the cerebellar tonsils in the middle. And then the nodulus is the little bit of tissue that can basically runs along with the flocculus behind the brainstem. So that's the gross anatomy. Now, the thing about the cerebellum is that the anatomy follows the rule of 3s. So always think rule of 3s. So we're going to start with our first 3. There are 3 cortical divisions in the cerebellum, right? There is the anterior lobe, this is a sagittal view, right? So this is the midbrain we've sliced through in the pons. So the anterior lobe is right up front, high and tight against the bottom of the cerebrum. Then there's the posterior lobe, which is the largest part of the cerebellum that we're going to talk about a lot today. And then there's the floccular nodular lobe, which are those bits kind of emerging from the front that you can see that actually runs all the way inside. This is what the cerebellum looks like unfolded. So if you were to take that fist and just kind of unfold it like this, you get the picture on the right. And so you can see the anterior lobe up at the top, the posterior lobe, which takes up most of the space, and then the floccular nodular lobe, which is kind of twisted inside, like if you tuck your thumb inside a fist. All right, there are 3 anatomical circuits within the cerebellum. There is the spinal motor circuit, which very much occupies the area of the vermis and this paravermal area that kind of surrounds that. There is a vestibular ocular circuit, which is most of the floccular nodular lobe and then little pieces of the vermis in the middle there. But the one we're really going to focus on today is the cerebral circuit. All right. And so this is really the vast majority of territory in the cerebellar hemispheres. And this is the one where the money is in neuropsychology. This is what we pay attention to. All right, there's 3 vascular territories to the cerebellum. The first is the superior cerebellar artery. That feeds the anterior lobe and kind of the first divisions of the posterior lobe here. You can see it from the back and then from the front. The anterior inferior cerebellar artery, or the AICA, that feeds the floccular nodular lobe and kind of the mesial aspects of the cerebellum. And then the posterior inferior cerebellar artery, which feeds the posterior and more lateral aspects of the hemispheres. All right, the PICA. Just to show you, so again, because we're talking about the hemispheres, this is really where all our activity is. By and large, rule of thumb to remember is that if you have a patient with a stroke with the superior cerebellar artery territory or the PICA territory, those are the strokes that are most likely to give you some cognitive impairments. All right, I want to show you, oh yes, right there, just from a side view to kind of look at what that vasculature is. I don't know if you've had a chance to do your vascular neuroanatomy section yet, but you'll see these are the vertebral arteries that are coming up into the posterior circulation for the intracranial region. So the first one off of the vert is that PICA, the posterior inferior cerebellar artery. So that actually emerges off the vert, goes straight back and supplies the bottom half of the cerebellum. If you travel a little bit up, as soon as the verts fuse into the basilar artery, the first thing off of that is the ACA, the anterior inferior cerebellar artery. And remember, that's feeding that middle piece. It's feeding the thumb in between in the fist. And then as you travel up just before the basilar splits off, then you see the superior cerebellar artery, and that's the one that's traveling over the top and innervating, again, the hemispheres and the anterior lobe on the top side of the cerebellum. The actual communication circuit, so the way that the cerebellum is connected to the rest of the brain, follows the two paths. It's a pretty sophisticated, it's a pretty efficient system. So the pathway to go from the cerebral cortex to the cerebellum follows this pattern. All right, it is the green. It goes from cortex, comes down ipsilaterally and synapses in the pons on the pontine nuclei, and then it decussates. So it crosses over to the contralateral cerebellum and goes straight to the cerebellar cortex. All right, so incoming information always follows this pattern. Now it goes through there's another three, the three bridges to the cerebellum. There's the superior cerebellar peduncle, the middle cerebellar peduncle, and the inferior cerebellar peduncle. So incoming information always comes in through the middle. Now information traveling from the cerebellum back to the cortex always follows a specific pattern. All right, so this is the cerebellar thalamic cerebral pathway. So it starts, information goes from the cortex of the cerebellum to the dentate. All right, the dentate is the major output nucleus to the rest of cortex. So it goes from cerebellar cortex to the dentate. Then it exits via the superior cerebellar peduncle. That's the main output highway from the cerebellum. And it travels, it decussates on its way up to the thalamus. So the first synapse is in the thalamus. And then from there, the transmission is back to the cerebral cortex. So this is a pretty efficient kind of 4 synapse system to get information from areas of cerebral cortex down to the cerebellum and back. All right, and that kind of pattern of connectivity is pretty widespread. So until probably 10, 15 years ago, this was a really radical idea. The cerebellum was a motor, it was a motor structure, all right? That's all that it did was help and control motor. And so while there may have been connections, there may have been information that was sent to the cerebellum from all other areas of the brain, the cerebellum only ever went back to the motor cortex. That's the only place the cerebellum talked to. Well, we now know that that is just patently untrue. And this is a map of the functional connectivity based on, I think, about 2,000 fMRI scans from the Randy Buckner's work. And as you can see, here are the areas that divided in the cortex based on whether or not they're visual, somatosensory, dorsal attention, ventral attention. So these are broken down by their functional circuitry. And you can see the correlated areas of activity in the cerebellum. And what I want to point out to you is that the motor section, so this kind of dark blue, is in very specific central parts of the cerebellum. Like I showed you before, it's that sensory motor, the spinal motor region is very much in the vermis and along, a little bit on the paravermal areas. But all of this lovely cortical regions that do all of our cognitive processing are very much connected to the cerebellar hemispheres. So there is a lot of conversation that goes back and forth between cortex and cerebellum. Okay, I think that's where we're going to stop with the most of the anatomy. There's a lot of really sophisticated internal circuitry that I'm not going to go into this time. I can answer questions about it if anybody has specific questions later, but I figure that the kind of molecular cellular based anatomy might be a little too involved and probably not necessary for the purposes of our intended use. But so this is the first quiz answer. All right. So the cerebellum contains what proportion of the brain's total neurons? If you guessed 60 to 80%, you are correct. Cerebellum actually has the vast majority of neurons in the brain, despite the fact that the cerebral cortex dwarfs it in terms of the intracranial space. All right. So any questions or comments yet? I will stop every once in a while to give people a chance to kind of ask. Nothing yet. Okay. Then let's, oh, sorry.
Doesn't look like we have any questions yet, but we'll definitely keep an eye on it.
Okay. So we've talked a little bit about the anatomical connectivity of the cerebellum. So the point that I want to make here is that the cerebellum is highly interconnected in a very efficient way to eloquent parts of cortex. We've talked about the functional connectivity. Well, let's talk a little bit about what that function might be. So what exactly does the cerebellum do with that connectivity? As I said, it's been typically considered to be a motor structure. And that's because the symptoms of cerebellar damage are so very obvious in a clinical setting. And I wanted to just kind of show you what some of those look like in patients who have cerebellar damage. All right. So these are classic motor symptoms. They are ataxia, which is a kind of unsteady or uncoordinated movement. Dysmetria, which is also uncoordinated in terms of its timing and extent. Dysdiadochokinesia, which is one of the funner words in neuropsych and neurology. Dysdiadochokinesia is a problem with controlled repetitive movements. Nystagmus, which is eye movement impairments, and dysarthria, which is speech impairment. So I want to show you an example of some of these. So up here in the top right, you'll see a patient who has an ataxic gait. Okay, so you'll see it's wide-based. It looks almost like he's skating. But the point is that he's unsteady, arms are out, takes a while to turn around. When you try and get him to tandem walk, which is to walk on a tightrope, they have to kind of hold on to something. This is an example of dysmetria. So the patient is going finger to nose, and you can see how at their nose range, they're reasonably accurate, but as they go farther away, the trajectory or the accuracy of the movement actually decreases. Let me see if I can back that up again and show you that. So it's kind of a targeting. It's like as they have to adjust there, and particularly when there's a moving target. So now they have to adjust on the fly. And they have that's the classic overshoot. So they'll go past where they need to go and have to correct and bring things back in. This is an example of dysdiadochokinesia. All right, so this is what we call the palm alternation. All right, so you see the patient there is kind of overshooting again. The coordination of that rapid alternating movement does not work very well. This is a lady with horizontal beating nystagmus. And so in this first bit, she's going to be told to move her eyes to look to the left and look to the right. And you'll see her eyes. See it twitch, twitch, twitch. That's a beating nystagmus. Okay. Now look, and it tends to happen on the side that's unilateral to the direction of gaze. Now she's going to be told to look up. Let's see. or sorry, so she has to move her head. And the idea is it's not only with the eye movement, so it's not just moving your eyes, it's actually keeping your eyes stationary and having your head move. You can evoke it in both ways. With cerebellum, it's oftentimes horizontal, it's rarely vertical in the nystagmus. And then I had a couple of examples of cerebellar dysarthria, but for some reason the audio won't load here. So I'm going to demonstrate a little bit to you. So ataxic speech is very kind of staccato speech. They have to do each syllable at their own rate because there's a problem with the kind of smooth coordination of that verbal output. Another kind of cerebellar speech that you will see at pretty much any bar. So you approach somebody who's been sitting at the bar too long and had a few too many, and they'll give this the slurring. That is also very much a cerebellar dysarthria. So the inability to kind of do that fine articulation, you will see in cerebellar damage. Okay. Now, so the theory has been that the cerebellum, its role in motor function is very much coordination movement. So the cerebellum does not produce movement on its own. If you take out someone's cerebellum, you do not paralyze them. All right, that's the idea. The cerebellum's job is to coordinate. It's supposed to fine tune. So it regulates the rate, the rhythm, the force, and the accuracy of movements that are generated elsewhere. It does this automatically and without awareness. All right. Now, you'll observe this in daily life too. If any of you have access to a 1-year-old who's learning to walk and that wide-based unsteady gait, that's ataxia. So it's very much the kind of, they're generating movements, but they're not fine-tuned. Now, the theory goes that the cerebellum, actually, what it's doing is it's using an internal model of sensory motor function. So that means that it has to understand what's the current state of information. So if I'm going to pick up a glass off the coffee table, I need to know where is my arm right now relative to that glass of water. I need to know what motor command I need to execute now. Okay, because if that motor command doesn't get the current state closer to the intended state, I need to change that motor command, and it's that change order that comes from the cerebellum. And if you use these 2 bits of information iteratively, what that allows you to do is to fine tune ongoing movement. Now, that change that I talked about in the last 10 or 15 years, with suddenly like, well, maybe the cerebellum does more than just motor. This is basically, there's a theory that the cerebellum, its general purpose is to do this kind of modulation. And it can do that with motor, but maybe it can do that with thinking too. So maybe it regulates the speed, the consistency, and the appropriateness of mental and cognitive processes. All right, so it doesn't generate cognition on its own, but it helps to kind of fine tune it. This is based on the fact that the structure, the actual cellular architecture of the cerebellum is exactly the same in every part of the cerebellum. As I mentioned, if you're somebody who really revels in like the beauty of organization, the cerebellum is that it's it, because it does this in a very, very efficient way. Another rule of 3, the cerebellum has 3 cellular layers that you can see here. Okay, there's a granule layer, which is this blue section down here, which has incoming information. There is the Purkinje layer, which is the outgoing layer. Oh, and now I just totally blanked on the word. I'm sorry. You're catching me without coffee in the afternoon. But the 3 cellular layers are the same regardless of where you are. And so the idea is that this architecture can effectively control motor. And it does the same thing in motor that it does in cognition, because it's designed by structure to do exactly the same thing. So they call that the universal transform. So on this basis, there are a couple of theories We're going to talk about one in particular today, about the role of cerebellum in cognition and how it might apply this same process to thinking skills. So there is probably the most well-known theory of cerebellar cognitive function is the cerebellar cognitive affective syndrome. And this has been proposed by Dr. Jeremy Schmallman, who is a neurologist in Boston. And he worked on a cerebellar stroke unit. And he started noticing the same thing, that patients coming in with cerebellar damage were showing these cognitive impairments. And he proposes that the cerebellum actually plays a role in particularly 4 aspects of higher order behavior. He argues that it plays a role in language, and that this is very much a function of the right cerebellum. So remember how I showed you that the cerebellar cortical connections are crossed. So the left hemisphere is specialized in language for most people, which means that the right cerebellum is likely connected, has a role in that language control. He thinks that executive functions are another role or another place where cerebellum is highly involved. And so that's the planning, set shifting, reasoning, working memory, those kinds of things. That is much more bilateral. The same as in cortex. We think that left and right are equally involved in a lot of these functions. Visuospatial skills, which again, given that there's typically a right dominance for visuospatial skills, this is very much a left cerebellar function. And then there is an emotional or affective component. He noticed that in a lot of his patients with cerebellar damage, there were actually some changes in their personality, their social comportment. And so he attributed this actually more to those midline that we didn't talk about so much, but that vermis, the little worm-like middle structure. And so this has been kind of the main theoretical basis for a lot of the cognitive cerebellar research that's been going on in the last 10, 15 years. And we're going to talk a little bit next about the what this looks like in patients. But first, we're going to go to our second question. All right, so the cerebellum constitutes what percentage of the brain's total weight? All right, we know that it's 68% of the neurons are there. How much of the weight does it account for? So if you guess 10%, that is correct. So despite the fact that it packs all those neurons in there, it doesn't weigh very much. Okay, so now I want to get to kind of what I think is the most interesting part, connecting the anatomy to the clinical presentation of patients that have disease or damage. So I'm going to walk you through 3 case studies. These are 3 patients. 2 of them I saw and 1 of them a colleague saw. So these are real people with fascinating histories and outcomes. So the first case was a 35-year-old right-handed single Caucasian male. All right. He graduated from high school. He joined the Army as a flight engineer, and he was doing helicopter repair. And he was doing some college courses when he was deployed. Now, he has no medical history of chronic disease, psychiatric background. He was a smoker since the age of 12, but otherwise is denying heavy drug or alcohol abuse or use. And he presents because he was the unfortunate victim of a gunshot wound. So when he was deployed, he got in the middle of a firefight, and a bullet entered about 2 centimeters in front of his right ear. So it basically came in right there. And it came through, went through a little bit of the temporal bones, the mastoid, which is in the bone in the back of your ear, and the posterior fossa, so the bottom of the skull, and it exited out the right suboccipital region. So it basically kind of clipped the side of his face and took out a chunk of his cerebellum as it went. So he had the area, he had a craniotomy or craniectomy. So they opened the skull and they got rid of the damaged tissue in the cerebellum that was kind of torn to shreds. They ended up resecting the lateral third of the cerebellum the day after the injury. So now he's got a reasonable chunk of his right cerebellum missing. He was brought back to the States and tested by neuropsychology 9 weeks after this injury. When you saw him, he had mild ataxia that was worse on the right than the left, which makes sense. So the cognitive functions of the cerebellum are crossed. The motor signs of the cerebellum are ipsilateral. And that's because the motor system actually double decussates. So the cognitive crosses once, motor crosses twice. So your right cerebellum will give you right-sided motor impairments. All right, and this is his neuropsych data. This is actually how he did on cognitive testing. And so I'm going to assume that a lot of you know what these tests are called, what they're for, and I'll just point out a few things that he had trouble with. So he was a little slow on a processing speed measure. His working memory was quite impaired. His memory was not great, but it wasn't that bad. It's still within reasonable normal limits. He again was really, really slow on more processing speed stuff. And he was slow on the Stroop test, right? So he was slow with color naming, word reading, but when you did the correction for the interference trial, he actually was only mildly impaired. His trails, both again, were very slow, but no errors. And then he did reasonably fine on the Wisconsin. When you talk to him, his speech was mildly dysarthric. It was kind of slow and it was very monotone. And as far as his behavior or his interaction style, it was all normal. There was no issues with his behavior or presentation. The other thing that I should mention is that he showed the motor problems. So he had the dysmetria. He couldn't, the kind of in coordination with those alternating movements. And we did a verb generation test where he had to generate a verb to a noun. So we'd say foot and he would say put on, or pool and he would say sun. So he had a lot of trouble with generating appropriate verbs to nouns. And those are really the remarkable parts of his presentation. All right, so then let me tell you about case 2. Case 2 is very different. This is a 77-year-old man, married, Caucasian, right-handed. He is 13 years of education, and he is a retired heavy equipment operator. His medical history includes hypertension, hyperlipidemia, diabetes, coronary artery disease, diverticulitis, and essential tremor. And essential tremor is really the reason that I saw him. So essential tremor is fascinating for a number of reasons. First of all, the tremor in essential tremor is one that kind of comes out when you start to do something. So the person at rest is quite still, but the moment you try and pick up a glass, then you get this tremor, all right? And that tremor is thought to actually be driven by impairments in the cerebellar thalamic network. So the activity between the cerebellum and the thalamus is irregular. It's idling at the wrong frequency, and it causes this tremor in the motor system. So I saw this gentleman. So he was smoking a couple cigars a day and an occasional scotch, which at 77, that seems to me to be reasonable. So I saw this gentleman because he was presenting for surgery for that tremor. We do a surgery where we'll implant a electrode in the thalamus, and we'll send electrical activity to the thalamus to try and correct that abnormal signaling from the cerebellum. All right. So he was coming in to have right-sided thalamic surgery for his left-sided tremor, right? Because it's crossed, remember? Now, the interesting thing about this gentleman was he came for the surgery, and 2 weeks later, he starts complaining of dizziness, right? He comes into the hospital. He's got mild ataxia on the left more than the right, okay? And he's got problems with rapid alternating movement. So he's got that dysdiadochokinesia. He's got a right gaze, horizontal gaze nystagmus. Okay, so he's got beating to the right side. And when we did imaging, he had an infarct in the left superior cerebellar artery. So remember, that's the artery I told you that's really the money, that's one of the two money makers for cognitive impairment after with stroke. So this poor guy has come in for surgery, and he's had a adverse event from the surgery. He's actually had a stroke. Chances are he had to come off some blood thinners for his heart disease, and that caused him to clot and sent a stroke into the SCA territory. The fascinating thing about him is that the stroke cured his tremor. The DBS system was never turned on. At the 2-week mark, we're still letting your brain heal. We don't turn that system on yet. The stroke actually damaged the part of the cerebellum that was causing the tremor. So this is kind of a 2 wrongs made a right for this gentleman. And that happened in 2006, all right? 6 years later, he is sent back to me because he is complaining of cognitive problems. He's having trouble remembering names, says there's a delay to he can't remember things when he needs them. It shows up a couple hours later. So I saw him for a repeat evaluation, right? So here are his cognitive scores. Oops, sorry. Here are his cognitive scores from when I saw him in 2006, before that surgery, and 2012, after the surgery. And what I'd like to point out here is the things that he declined on were the verbal fluency measures. So his semantic and phonemic word generation fell pretty substantially. There's also a bit of a change in his judgmental line orientation, but he had a scaled score of 16. So this was really, really good. And so now he's down to average. So I'm not making a whole lot out of that potentially, although it's good to note. And then pretty much everything else, I mean, his Wisconsin normatively stays within normal limits, but really he falls from getting 6 categories to getting 1 category. So there may be a bit of a change here too. As far as his memory goes, his delayed memory falls again from that, superior range down to an average level. So there's a bit of a change there, but his recognition still stays really good. As far as his behavior goes and his affect, again, totally fine. No problems there whatsoever. Okay. So now I want to tell you about a third case, a different kind of cerebellar damage, right? This is a lady that I saw, 45 years old, right-handed, married, 18 years of education. She was a teacher, and she had been fired a year before I saw her because she was having trouble keeping up with her work. She also had a past history of hyperlipidemia, hyperthyroidism, obstructive sleep apnea, migraine, and depression. She was not using any substances or alcohol. Her initial symptoms started with slowed speech 10 years before I saw her. So she had started to slur her words a little bit, right? By the time I saw her, she had severe dysarthria and she had the slurred type. So it was really difficult to understand what she was saying because everything was slurred together. I mean, you really had to work to understand what she was saying. She had pseudobulbar affect, which is a condition where you express an emotion that you're not feeling. So people will begin to cry when they're not feeling sad, or they will just laugh hysterically when they don't think something is funny or they're not happy. So that what they're showing on their face, what their affect is, does not match their emotion. There's a medication for that called Nuedexta. It works pretty well, and it had worked for her pretty well. But there was clearly a difference in her emotional function. She also showed that nystagmus, which was pretty dramatic. It was hard for her to read, do anything, she couldn't drive. A lot of dysmetria, a lot of that rapid alternating movement, dystatokinesia problems, ataxic gait, and she was incontinent of urine. Now, the MRI is pretty messed up a little bit with motion, but it was thought to be pretty much age appropriate with normal. Her cerebellum looked normal to radiology. Her complaints were slowed speed of processing. So it just took way too long to kind of think through things. Her organization had just gone completely to pot because she used to be very organized as a teacher. She was much more distractible, and she had trouble finding words that she wanted to use. So here is her cognitive profile. All right, and first of all, we did not try any speeded oral measures. So fluencies or Stroop, we didn't even go there because her motor deficits were so bad. Her speech was so bad that she was going to be impaired, and that may have nothing to do with the speed of her cognition, her actual word retrieval. So we tried to do things that were more motor based. So trails, she was a little slow, but still no errors on trails. Let's see. Her BNT was low. So her actual word finding, and she really only queued up 5 times. So there were only 5 words where giving her the phonemic cue actually led to the word retrieval. Motor versions of processing speed were also very slow. Let's see. Her motor function was slow, so her pegs were impaired. Notably, her story memory was also impaired. All right, so she had trouble with immediate and delayed read. It was mild, very mild, but probably not as good as it should be. And similarly with her CVLT 3, she showed impaired delayed recall. All right. Wisconsin was not ideal, probably low for somebody with 18 years of education. But she was not complaining. I mean, she was showing complaining of some mild depression, anxiety, but not so bad. Her affect, she looked consistently surprised. So she had this look on her face like all the time, regardless of what was going on. So while she wasn't laughing or crying inappropriately, she had this kind of wide-eyed look on her face all the time, but otherwise completely appropriate interpersonal interaction. This is her RAO, all right, which is technically impaired. But what I'd like you to take away, so the patient's copy is on the left and the technician's copy is on the right. Whoops. Sorry, there we go. What I want you to take away from this is the order in which she did things. So the order of the colors is below here. So she did this in a very piecemeal and disorganized kind of way, right? Which led to kind of disjointedness and distortions in her overall production. Okay. All right. So let's compare those 3 cases. All right, we have 3 very different kinds of cerebellar damage. All right, we have a subacute right hemisphere excision. We have a chronic left hemisphere stroke, and then we have a progressive, likely diffuse process. All 3 of them kind of fairly specific to cerebellum. So this is their language profiles, and really what you see here is that in that subacute right hemisphere, which arguably should be the hemispheric damage that produces language problems, the patient's really only major problem was in verb generation, with a little bit of mild dysarthria, which is motoric, but otherwise language was fine. The patient with left actually had no verbal problems, but then our diffuse patient had clear problems with naming and severe dysarthria. So there is a small pattern of, this seems to be language problems. Sorry, that's my cat, Izzy. She wants to say hello. With cerebellar damage that does involve the right hemisphere. All right, so that seems to match with what we'd expect based on the cognitive cerebellar affective syndrome. Okay, this is the executive function or executive and complex attention working memory kind of profile of those 3 patients. All right, and what I'd like you to see is, oh, this is all out of order. So our right hemisphere patient, really, I mean, it was very much his fluency. Oh, this is way out of order. I'm sorry, that's all over the place. We'll just fill this all out. there are executive deficits pretty much across all three patients. Okay, all the patients had some form of executive problem. Now, remember, we're being very careful to make sure that we're not considering a motor impairment and a cognitive problem. All right, so for our diffuse patient here who was really slow, her trails B was impaired, but so was A. And when you did the difference, it was okay. All right, so then let's look at visuospatial function. So again, based on that kind of crossed function, we would expect that potentially left cerebellar damage is where you're going to get some visuospatial problems. And our right hemispheric patient really didn't have visuospatial problems at all. Our left patient had a little bit there. Jolo had dropped. That's the one where he went from being superior to being average. And our diffuse progressive patient had a poor Rayo copy, which I would argue is probably more related to her disorganization than her visuospatial function. So this is a less kind of convincing picture in these three patients for visuospatial problem with left-sided cerebellar damage. And then let's look finally at that emotion component of the cognitive affective syndrome. All right, so our subacute right hemisphere patient, no issues with emotion or motion regulation or behavior. Same thing with our chronic left patient. It was really only the diffuse progressive patient where there was an issue here. And remember, the emotion-based deficits, Dr. Schmalman thinks are very much in the kind of central region, in the vermal region. And so our two patients with clearly lateralized deficits aren't showing a problem, but the lady with the diffuse, likely involving the central part of the cerebellum as well, does show some emotion changes. So this also fits. So there is some evidence to suggest there might be something to that, that theory. There's clearly more work to be done, and people have been working on that kind of consistently. So in thinking about how would you approach a patient from a neuropsychological perspective that comes in with cerebellar damage. One study actually went through the literature and tried to collect all of the studies that did a full neuropsych evaluation in patients with circumscribed cerebellar to find out which tests seemed to be the most sensitive to cerebellar damage. And they recommended that the block design test, the fluencies, which I showed before, the Stroop test, and the visual memory scales from the Wechsler are probably the most sensitive to cerebellar damage. And these do pick up on those verbal, visuospatial, executive pieces that we've already talked about here. Now, the other thing to keep in mind when you're seeing a patient that's coming in with cerebellar damage is watching for their speech, right? So if you've got somebody with that dysarthric ataxic speech, you have to be very careful that your verbal tests take into account any speed problems that are related to that dysarthria. So your speed tests require a true control condition. So that is very much, comparing your interference trial on the Stroop with the color naming or the word reading. When you're doing phonemic or semantic fluency, you can actually do the comparison between either of those by themselves with perhaps the switching component on the decafs. Because then with the switching, you're taking into account already that kind of reduction in any speed or generation slowing to look at the higher order executive function problems. When you've got a patient coming in with those more motor-based manual ataxic or incoordination syndromes, you need to be very careful about how those manual responses will slow their or make their responses imprecise. So in those cases, looking at time on trails may be less important than looking at the errors on trails, again, because you're looking at the failure of the sequencing piece rather than the speed. The same with things like Tower or Wisconsin. You're looking less at timing measures and more at accuracy measures. And again, making sure that you've got a control condition for that motor. So looking at trails B only in the context of their speed on trails A. And then finally, keep an eye on those eye movements. You're going to want to kind of look to see if there are nystagmus present for your patient, because anytime you're giving a test that requires visual scanning, you're going to run into problems. So that Stroop test may not be a good option because the patient will not be able to accurately scan across a line. In which case you want to rely more on things that are much more kind of foveal based. So things like a Hooper organization test or the JOLO. Something that has a much more restricted field of view that doesn't require eye movements to gather information about the stimuli. All right, so then clinical takeaways in your study of your testing of cerebellar patients. The first one that I really want to kind of show, I hope that the 3 case studies show you that there really is no pathognomonic neuropsych deficit for cerebellar damage. No patients, there isn't one thing that you test for to say, oh, this patient has a cerebellar lesion. That's very, very dependent on the location of damage potentially and the kind of damage the patient has. Your expectations for abnormal performance are going to completely depend, like I said, on the location and extent, but also think about the possible involvement of non-cerebellar structures. So patients who are coming in with more diffuse kind of gradual neurodegenerative type pictures that are highly cerebellar can still have damage at a distance. And you need to be taking that into account when you're trying to attribute deficits on testing to anatomy. And then finally, you need a thorough understanding of the patient's motor deficits to guide your test selection. So you need to understand where the patient has cerebellar-based motor problems. Is it eye movements? Is it speech? Is it manual dexterity? Because you're going to need to select your test and do your interpretation around those kinds of problems, because that can cloud what your conclusions are going to be. And then finally, if anybody is really interested in test development, I think that there's a lot of room to try and develop tests specific to the cerebellum and its role. I mean, these tests are designed more for cortical regions that are kind of driving the production of these behaviors rather than modifying them, whether that's, the timing, the rate, the accuracy, those kinds of things. Developing tests that are specific to the modulation of activity that's being done elsewhere is going to produce greater yields for understanding the cognitive deficits with cerebellar damage. All right, last question. So if it's unfolded, how much of the cerebellum surface area, or how much of the cerebrum surface area would the cerebellum cover? All right. If you said 50%, you would be right. So the cerebellum actually, despite the fact that it doesn't weigh much, has a lot of surface area. There's a lot of little folds in there. And if you took it apart, it would look about half the size of the rest of the brain. All right. So I'm going to stop there and open for any questions.
Thank you so much. That was such a fabulous presentation. And I mean, I'm sure I can speak on behalf of everyone that I personally learned a ton, and it was just absolutely wonderful. I particularly liked your color coding. Definitely helps organize things quite well in terms of perfusion of the cerebellum and organization. Loved it. We do have a couple of questions, one of which actually you did talk about it a little bit earlier, and every patient, of course, is going to be different, but generally speaking, what is your understanding of some of the kind of key language deficits that you do tend to have, particularly in right-sided cerebellar strokes? Is it word retrieval? Is it naming? Like, what's the typical pattern that you see?
So you don't, so the theory says that you should see anomia, right? So patients are going to have a hard time with word finding. You don't see that consistently, frankly. I mean, generally speaking, word finding problems are kind of they're like a fever in neuropsychology. Everybody has word finding problems. But most people will queue up to that. And I find that cerebellar patients are the same, again, because the cerebellum, it's not supposed to be generating that language. It's supposed to be guiding your way to it, basically. So I think you will find that patients generally do queue up for that. So if you see a true anomia, that's not typical of cerebellum. I think probably the most common one is the verbal fluency piece. And the trick is, taking into account any oral slowing for the patients. The thing is that you will see that in patients who don't have that kind of oral problem. So you still see that kind of slowed production, or I mean, what I like to look for is not so much how many words do they generate, look for the strategy behind that. How much clustering are they doing? So, I mean, if they're giving you, S words, are they doing, the SAs and then the SCs and then the SIs? Are they doing, or with their, are they doing, I'm going to do barn animals, then I'm going to do African animals, then I'm going to do, so I look for that, how long they can stick with that and how many times they switch those things. Because I find that the cerebellar patients are much less flexible about doing that. So they're producing less, but they're also showing that poor kind of strategy piece.
That makes a lot of sense, particularly with the executive function difficulties they see, and with their slower processing speed, that they're going to be probably have poor scores. So that makes a lot of sense.
Yeah, you don't see a lot of like sentence comprehension problems. Those kind of more basic aphasic kinds of pictures is not what you're going to see there.
That makes sense. Thank you for answering that question. Another question was, there's curiosity as to your takeaway from your 3 patients, particularly with left-sided cerebellar damage, not having that visual spatial, not really seeing that visual spatial deficit. What is what's your understanding of that?
I feel like it very much depends on how you design your test battery. I think a lot of the deficits, again, in my mind, kind of come down to more the executive piece. So the cerebellum is not generating those spatial relationships. It's trying to use the spatial relationships that are there to the best extent that they can. And so I feel like you don't get any, there aren't the agnosias, you don't get the, kind of left neglect kinds of things. You don't see, I don't see primary visuospatial. I see that organization and more kind of control piece is applied to a lot of the visual, that in my personal experience anyways. That syndrome that I talked about, that cognitive affective cerebellar syndrome, is fairly controversial. It's simply the most well-known one. And so I think you always have to take these things with a grain of salt, not going in with a kind of, Moses came down with this on a 3rd tablet from the mount kind of thing. So I very much, I see, you're going to see that organization applied to those visuospatial things rather than being a visuospatial problem in and of itself.
Makes a lot of sense, especially because even on your array, the gestalt was intact, but it was very piecemeal, as you said. Yeah. We had another really great question. The question was if you see differences in testing for cerebellar issues, particularly in regards to gender or age, adult, pediatric, older adults.
Right. So that's a really good question, because another kind of quiz question I like to do is, at what age is the cerebellum fully developed?
That's a good question.
And it mirrors the frontal lobes. It's not fully developed until you're almost 20 years old. So it's again, my example of, kind of the 1.5-year-old who's like doing the furniture walking kind of thing. That is an ataxic patient. They look like a toddler basically, because they don't have that fine control to kind of set themselves up. That's very much the stage at which the cerebellum is still kind of figuring out its organization. And so the damage to the cerebellum, if you think about, things like Chiari malformations that we, see a lot in pediatrics. You'll see some executive kinds of things there that are emerging as the kids get older, but you have to recognize that they might be growing into these lesions, depending on what the pathology is for that particular patient. But there is a very clear developmental trajectory that you need to take into account with cerebellum. And again, the etiologies, that's the brain is a marvelously kind of flexible thing. So probably the most relevant piece, which is another thing I didn't get a chance to get into, is that some of the areas that people are thinking about cerebellar contributions to syndromes are in the pediatrics realm, and they're specific to that social cognition piece. So autism is a huge area of research right now. There's they're working on, data to understand how this abnormal cerebellar structure is contributing to the social deficits that kids with autism show.
So fascinating.
Yes. And again, I mean, you think about autism, that's very much, I mean, it's not a generation of the behavior. It's kind of how do I, kind of use and manage and appropriately modify behavior. And that fits squarely into the cerebellar realm.
Oh, well, we just cannot thank you enough for lecturing today. Thank you so much. It was just really wonderful. We appreciate it. And for everyone else joining us, feel free, please come back next week for Dr. Christine Mullen lecturing on sensory pathways. Thank you.
All right. Thanks everybody for your attention. Have a great day.